Our next speaker is Dr. Elizabeth Lynch, Medical Director and owner of Sleep Institute of New England in Kingston, New Hampshire.
Okay, so the purpose of the talk today, I'd like to describe the types and the prevalence of sleep apnea, its meaning for patients who are at risk or who already have cardiovascular disease. I gave this talk about a year and a half ago for grand rounds for the docs at one of the hospitals. And about 2 weeks ago, I thought, okay, I'm going to use the same talk, lots of same information. I'm just going to go to the literature and see, what are the new things maybe that happened in the last year that I should sort of add here and there in the literature or into the talk. And so over the last year, there have been 240 articles on sleep apnea and cardiovascular disease. And that's only in 2012. If you go back to 2011, there were 321. So I tell you, I did not review 561 articles in the last 2 weeks. I did not do that. I tried to pick and choose things that might be interesting to bring back into the talk. But my point in saying that is that the field is just sort of busting open in terms of all the literature that's out there right now on sleep apnea and cardiovascular disease. And I think that we're just going to keep seeing it more and more, and it's just going to really sort of evolve. And it may, in terms of its impact on you, is there are already different forms of positive airway pressure delivery systems for potentially different disease states. And so as techs, in the future, we're going to have to really sort of know, okay, which ones are better for which patients. For the most part, CPAP is always the thing to start with first, so the emphasis on the talk will be to recognize patients with cardiovascular disease and those who have coexisting sleep apnea, understand the mechanisms by which sleep apnea may contribute to the progression of their cardiovascular disease, and then review how specifically CPAP, because that's the mainstay of therapy right now, but review how CPAP can help that. The main questions, I think, in general, in the medical world on sleep apnea and cardiovascular disease does sleep apnea initiate the development of cardiovascular disease? Does sleep apnea accelerate the progression of cardiovascular disease? And then also, does treatment of sleep apnea cause fewer cardiovascular events and reduce mortality? And at least for those last two questions, I think there's probably enough evidence right now to say, yes, the answers are yes to both of those. The causality, do you initially develop cardiovascular disease when you have sleep apnea? That would be the first question there. Is developing, but it's not, slam dunk, yes, this is definitely causing this in the literature. So as you all know, we have lots of letters. And I'm just going to review them here quickly because I use them a lot in my lecture. So SDB, sleep disordered breathing, UA, upper airway, OSA, obstructive sleep apnea, that, CSA, central, CSR, Cheyne-Stokes respiration. I'm going to go over these if they're not second nature to you. AHI, apnea, hypopnea index, CAI, central apnea index, positive airway pressure is PAP, and then CPAP, APAP, VPAP, BiPAP, all the PAPs in the world that you want. So we all know a lot of the PAPs. So sleep disordered breathing and cardiovascular disease. How often do we see it? What is it? Where is it? So it is highly prevalent in cardiovascular patients. It affects at least 15 million, and when I was reviewing the literature, I think it's more like 18, and I even saw one paper that said 38 million. So I'm not really sure exactly, if it's 15 million, 18 million, 38 million, but I know it's a lot of millions. So it definitely affects a lot of us. It can present or be involved with, as you already heard from the last speaker, because I heard the last 10 minutes or so talk, atrial fibrillation, stroke, coronary artery disease. Central apneas are seen, central sleep apnea is seen a lot with heart failure. If you look at the numbers down below here, we see in general about 50 to 60% of patients who have had a stroke have sleep disordered breathing. In drug-resistant hypertension, so that's patients on 2 or more antihypertensive medicines that do not have very good control of their blood pressure, 80% of those patients have sleep apnea. In congestive heart failure, about 50-50. In just run-of-the-mill antihypertensives, about 45%, 40-45%. Coronary artery disease, about 30%. And I don't have one I should add, and that is diabetics. So we're seeing about 40 to 50% of diabetics have sleep-disordered breathing as well. In years past, there have been limitations in looking at the publications that have come out on the associations of sleep apnea and cardiovascular disease, because many of these studies, for example, were not able to sort of tease out the relationship between obesity and sleep apnea, and was it really all just secondary to obesity and not necessarily sleep apnea as an independent risk factor? And I think that especially the studies that have come out over the last 2 years are really teasing that out better and saying, yes, it is an independent risk factor. It's not necessarily just diabetes. We see multiple comorbidities with sleep apnea, so many times sleep apnea patients have a lot of other things going on. They've already had a heart attack, they have a metabolic syndrome, they have hypertension, they have diabetes. And then also the studies, as I reviewed the literature over the last 2 years, we're seeing more sort of randomized controlled trials, but in years past, they were sort of case studies and cohort studies and review of literature, and there's not a lot of power in those studies. So they say, oh, we need these randomized controlled trials to really know if there's an association or not. The other thing is, if you have somebody who is a truck driver or a pilot or a school bus driver, if they're really sleepy during the day, you're not going to randomize them to treatment or no treatment. You're just going to give them treatment. And so automatically, you're not able to do a nice randomized controlled trial because of the very severe nature. You know, when people have bad symptoms, you're just going to go ahead and treat. You're not going to randomize them to one group or another. So that influences the literature that's out there as well. Okay, so the things that I'm going to cover in the talk, definitions, which hopefully is all a review to all of you, diagnosis of sleep apnea, and then I'm going to kind of delve into the pathophysiology of sleep apnea a little bit, which is often confusing to a lot of people, not only me, but others. I tried to sort of review the pathophysiology of central sleep apnea yesterday, and there was this paper that I came across. It was 66 pages long and really, really small print. And I'm like, you know what, I'm not going to read that last night. I'm not going to do that. I'm not going to sort of review all of that. You could actually have a whole entire lecture right now on central sleep apnea. As if any of you were at the Sleep 2012 conference, I sat in on Atul Malhotra's session talking about central sleep apnea. And you could just talk a whole hour or 2 hours just on that. But anyway. So then I'm going to go into a little bit of the cardiovascular disease states, the high blood pressure, the heart failure, the stroke, the arrhythmias, and sort of talk about each one of them individually. Okay, so this is a review, right? Obstructive apnea, repetitive cessations in ventilation during sleep. We all know that, caused by collapse of the pharyngeal airway. And this is a 5-minute window of sleep. This is your nasal pressure, your airflow, abdominal belt, thoracic belt, abdominal belt, and your O2 sats. And you can see, no airflow, then they start breathing, no airflow through the nasal pressure and the airflow channels. And so it looks very classic. You have effort going on down here in the thoracic and abdominal belts, so very classic for obstructive sleep apnea. Obstructive hypopnea, very similar, repetitive interruptions in ventilation during sleep caused by incomplete collapse. So it's narrowed, but it's not completely blocked off. And here are some good ones where it sort of decreases, but it doesn't necessarily go to zero, and you have your effort in your thoracic and abdominal belts.